Hello everyone, I am Dr. Sarita Jaiswal, Program Director of BMT at Dharamshila, Narayana, New Delhi, and a researcher at Cellular Therapy and Immunology, Manshi Chakravarti Foundation from India. The question is, how can CTLA4Ig-primed sequential DLI improve chronic GvHD and relapse-free survival after an allogeneic transplantation? Here we are talking about exploitation of a unique property of CTLA4Ig beyond T cells, that is a positive impact on NK cells, and how this has been translated to clinical practice by our group since 2015. T cell co-stimulation blockade via CTLA4Ig binds to CD80 and 86 on antigen-presenting cells. It prevents T cell co-stimulation and thus its activation. Based on our earlier experience on early donor lymphocyte infusion, we evolved a protocol where DLI at a dose of 1 to 5 million cells per kg was infused within 12 hours of administration of CTLA4Ig to patients on days 7, 21, and 35 post-transplantation. We used only a short course of cyclosporine apart from PTCY. We witnessed a marked reduction in disease progression in 75 patients with very short course of cyclosporine apart from PTCY. We witnessed a marked reduction in disease progression in 75 patients with a very high risk acute leukemia. The incidence of acute GvHD and NRM were less than 10%. There was a strong association of relapse-free survival with proliferation of mature NK cells with CD56 dim, NKG2A negative KIR phenotype. In addition, there was a significant upregulation of CD86 receptor on NK cells. The incidence of chronic GvHD was only 18%, mostly mild or moderate. In those developing GvHD, NKG2C positive adoptive NK cells dropped with an inverse increase in NKG2A positive, NKG2C negative subset. Interestingly, this reversed following subsidence of chronic GvHD. Hence, this suggesting that NKG2C adaptive NK cells might have a distinctly beneficial impact on reducing chronic GvHD when CTLA4Ig DLI was used. On further exploration of this phenomenon, we witnessed an early and sustained expansion of adaptive NK cells, which were NKG2C positive, 2CA negative in patients who did not relapse. The level of adaptive NK cells were sustained over a 3 years follow-up with equally brisk and sustained level of Tregs. There was no late relapse. One might ponder if Tregs would adversely affect the cytotoxicity of NK cells. It definitely does so for conventional NK cells, but not for adaptive NK cells, as they are resistant to Tregs-mediated suppression. We believe that the simultaneous expansion of both adaptive NK cells and Tregs played a critical role in amelioration of chronic GvHD. The GvHD and relapse-free survival was over 70% at 2 years in these 75 patients of high-risk acute leukemia. This novel platform of CTLA4Ig-primed DLI, where a strong GVL effect could be sustained without GvHD, is an exciting development in the field of allograft. Thank you.